You are welcome to my channel. Thanks for visiting. Remembering to subscribe, listening to all my presentations, and sharing them. Today, we are going to be addressing typhoid. Generally, typhoid is also known as typhoid fever or paratyphoid fever, but people do use enteric fever interchangeably with typhoid fever. Enteric fever is meant for both typhoid and paratyphoid fever. Typhoid is an invasive bacterial infection acquired through contaminated food and water. Salmonella typhi may be transmitted by water, while Salmonella paratyphi may be transmitted by food. When we are talking about infectious disease, we must identify the culprit, the agent responsible. Here, Salmonella entericus serotypes typhi, formerly known as Salmonella typhi, also Salmonella entericus serotype paratyphi A, Salmonella entericus serotype paratyphi B, and Salmonella entericus serotype paratyphi C are the known agents responsible for typhoid and paratyphoid fever, also known as enteric fever. Epidemiologically, enteric fever is more common in children and young adults than other patients. Why that? We'll know as we move on. The only reservoir known are human beings. Street food vendors are major spreaders. Western world patients are only affected after making trips to the endemic zones of the world. The endemic zones of the world are African countries, Latin America, South Asia, and Central Asia. Vaccination will prevent this horrible fever, enteric fever, amongst travelers. We'll go over vaccines meant for typhoid in a bit. Contact is mainly through food and water. Specific contact can be identified in some cases. It is more in regions with poverty because we'll be dealing with overcrowding, poor sanitation, sharing of utensils, lack of soap to wash hands or general cleaning, or lack of good toilets or washrooms, depending on where you are. In Canada, it's washrooms. Chronic salmonella carriers. That will be, addressed separately because it's pretty important when it comes to typhoid fever. The chronic salmonella carriers are capable of excreting the organism in stools or urine in up to and even more than a year after primary acute infection. Let me explain. Meaning, an individual must have been infected, and more than 1 year after being infected, they can still spread the microorganisms through the stools and urine. Chronic carriage occurs more in women. We will understand a bit as we progress. Cholelithiasis and other biliary anomalies can lead to chronic carrier status. Chronic carriers that are food and water handlers will likely infect more people because the more people drink water from them or eat food from them, the more likely that many more people will be infected. Stages. There are 4 distinct stages, and each lasting at least a week. The first stage, or stage 1, will be characterized by mild fever and sometimes no fever at all. There may be headache, weakness, and this may be associated with cough that will be dry, meaning it will be unproductive. The second stage, or stage 2, will be characterized with high fever, weight loss, abdominal distension, agitation, or lethargy, with or without hallucinations. Stage 3, or third stage, will be characterized with more advanced disease stage. Here, there may be intestinal perforation, treated with bleeding, and massive bleeding will lead to hypovolemic shock. And sometimes, perforation with septicemia can lead to septic shock, dehydration for massive bleeding, prostration, high fever, encephalitis affecting the brain, and delirium. The stage 4, or the fourth stage, will be known with complications. And the complications here will include renal failure, pneumonia, meningitis, pancreatitis, endocarditis or myocarditis, multiple organ failure that will lead to coma, and if no urgent attention that is appropriate, death. Clinical features. The clinical features of enteric fever, remember, enteric fever simply means typhoid fever or paratyphoid fever. So the enteric fever for 5 to 21 days post-ingestion or acquisition of the salmonella in food or water will be the case. And here we'll be dealing with fever, chills, and abdominal pain. The first week, there'll be rising in a stepwise fashion of fever and bacteremia, meaning the fever will not just come suddenly and then it's going to be high, immediately. No. The fever will be coming gradually, might be 37.5, not today, then few hours or tomorrow it's going to be 38.5, 39.5, just in step ladder fashion, as if you are climbing up. So it will continue to go up gradually, not suddenly. Chills are typical, rigors are less occurring, and the heart rate may drop, bradycardia. That is the first week. In the second week, there may be abdominal pain. Rose spores may be found, which are salmon color macules on the abdomen and the trunk. At the third week, there may be hepatomegaly, splenomegaly, intestinal bleeding, intestinal perforation that will occur at the ileum, peritonitis, bacteremia, septic shock, altered level of consciousness, and multiple organ failure that may lead to death. When it comes to intestinal perforation at the ileum, let me explain further a little bit here, because in fact this is when we will need the surgical department to help us solve medical problems. Here, this is due to ileocecal lymphatic hyperplasia of the pair patches with peritonitis and bacteremia. Once there is intestinal perforation, that may be due to necrosis of the pair patches at the antimesenteric bowel wall. There will be increased level of abdominal pain, associated with abdominal distension, peritonitis, bacteremia, and aerobic as well as anaerobic microorganisms. When it is greater than 3 weeks, up to 3 months, then there may be resolution that will start gradually. Okay? Older adults will likely have constipation more than diarrhea. Diarrhea will be more than constipation in HIV positive patients or adults with HIV and children and the young adults. Let me explain. When it is greater than 3 weeks going to months after acquisition of the pathogen and infection thereabout, then resolution will begin, but it's going to be gradually. Remember, the fever will also be step, wise fashion, step ladder, as if you are climbing up. So resolution will also be as if you are descending, you are coming down gradually. Older adults will have constipation more than diarrhea. But younger people and children and adults with HIV and everyone with HIV will likely have more diarrhea than constipation. So abdominal pain might be present with distension, and there may be rectal bleeding. Okay? Intestinal perforation is more in adults than children, and that will lead to more mortality. Intestinal perforation because there will be need of surgery, more bacteremia, overwhelming sepsis, septic shock, multiple organ failure, and so on. Okay, more on intestinal perforation. I've written it there, ask me, and someone will ask, why are you so much concerned about intestinal perforation? Well, from mild typhoid fever to medical emergency, now to surgical emergency. Here, the problem is because at the ileocecal lymphatic region, there may be apoplasia of the pale patches, associated with peritonitis and bacteremia. And once there is intestinal perforation, the perforation which will likely be due to necrosis of pale patches at the antimesenteric bowel wall, there will be increasing level of abdominal pain. There will be abdominal distension. There will be peritonitis everywhere, and bacteremia will be the case. And that will include aerobic bacteria as well as anaerobic microorganisms. So in that case, we will need surgical intervention. We will need very broad spectrum antibiotics covering both aerobic and anaerobic organisms. Still on clinical features, the central nervous system is not spared here. Neuro issues are associated with typhoid, and that will include headache, sleep disorder, or altered sleep pattern. I've seen a case in those days of someone with typhoid, admitted in the hospital, being given antibiotics to cover the microorganism, but then we ran into insomnia as well, and then we needed to sort that out. So that might be acute psychosis. Okay, although you have to be careful, particularly in regions of the world where malaria could also be endemic and typhoid is also endemic. So be sure you are not dealing with cerebral malaria, so rule that out. Then myelitis, rigidity, meningitis, aparaplegia, spasticity or sustained clonus, that is upper motor neuron lesion, ataxia, and sometimes Parkinsonism. And maybe typhoid encephalopathy, characterized with delirium, altered level of consciousness, confusion, obtundation, stupor. You can use strong or broad spectrum antibiotics here, and in addition to that, you had your dexamethasone. Other non-intestinal problems will be cough, pneumonia, febrile seizures in children. There's a self-representation on that already published by me. You can check my channel to get full info about that. Arthralgia, joint pains. Myalgia, muscle pains. Certain symptoms will be profound in HIV patients. And you ask me, what are those symptoms? They can have more diarrhea, than constipation. They can have greater probability of having intestinal perforation. They may have arthritis and chorioamnionitis. Chronic carriers. Here, there may be no recurrent symptomatic disease, but chronically colonized with high serum antibody titers against V1, and the microorganisms are kept in the biliary tract. Remember, I said it while reviewing the epidemiology that it will be common in women, particularly those with cholelithiasis. Biliary tract, hidden in the gallbladder, you understand, may excrete large numbers of organisms, that is, chronic carriers. Still on chronic carriers, they are capable of excreting the microorganism in stools, in urine, up to and even greater than 1 year after the primary acute infection. Chronic carriage occurs more in women. Patients with cholelithiasis and other biliary anomalies can become chronic carriers. Carriers that are water or food handlers will likely infect more people. S. paratyphoid will be passed by food, while S. typhoid will be passed by water. Still on chronic carriers, shedding S. typhoid in stool for 12 months after infection, and all food handlers should be tested. They have increased chances of having gallbladder carcinoma. They can have cholecystectomy to eradicate the carrier stage in them. May choose strong antibiotics to deal with chronic carrier status, such as ciprofloxacin or floxacin, rivampin, Bactrim, or Septra. Differential diagnosis of typhoid fever. Like while explaining the other time, I alluded to the fact that malaria might be present. Malaria may present like acute psychosis in cerebral malaria. You can check my channel for cerebral malaria already published. Okay, so one of the differential diagnoses here is malaria, amoebiasis, dengue fever, draw fever, leptospirosis, fever of unknown origin, spontaneous bacterial peritonitis, sepsis. Bacteremia, Q fever, leishmaniasis, melioidosis, HIV infection, gastroenteritis, community-acquired pneumonia. How can we make diagnosis here? Enteric fever can be suspected in anyone from or living in the endemic zones for typhoid. Let me explain. High index of suspicion will help greatly. Whether by the time we go into all the diagnostic procedures that may be difficult to do in some centers because of unavailability of the technical know-how or equipment, then we'll understand that high index of suspicion will save many lives. So somebody has just traveled, maybe you're in the Western world, you're in the US or Europe, Russia, but somebody has just traveled from your country to another country that is listed as endemic as per typhoid, and he or she is back right now, down with the clinical features we've just gone through. High index of suspicion will help, although you might have the gadgets to do the necessary investigations. But some in the endemic zones don't have the gadgets to do all the necessary tests and radiological investigations. So since you are living in endemic zones and the clinical features are presenting the way we've gone through, then you can just make the educated guess that this is typhoid fever. The history of the abdominal pain with diarrhea or constipation should raise the concern about typhoid when there is link in one way or the other to the endemic zone. Either you are living there, or you travel from there, or you are visiting right now. So we can then embark on gamut of stuff to be done like blood culture, stool culture, urine culture, rose spot culture. But bone marrow culture is the most sensitive. So, isolating Salmonella typhi or Paratyphoid from culture will be necessary. Protracted febrile illness without other explanation is enough in regions without the resources or cultures that are negative. Let me explain. Like I've just said, about 2 minutes ago, that if you are living in a region without, the gadgets to do all the necessary investigations, and the person is presenting with clinical features suggestive of typhoid, that's enough for you to make the diagnosis, please, because typhoid can kill. Okay, so when there's protracted febrile illness, and you sought for what could be responsible, and there's none, and this person is living in a region where you cannot have bone marrow culture, you can't do much, or you've even done your culture, the outcome is negative, but you are suspecting that typhoid is the case, you can go ahead with the treatment. You can have microscopic culture and sensitivity before the use of empiric antibiotics. Wider tests, meaning serological tests. This is what many poor centers would do, but let's go through what the issue is here. It detects anti-Salmonella typhi antibodies. The usefulness is pretty limited, so not very much useful, because past infections may lead to positive results today, particularly in people that are living in endemic zones. Unfortunately, they are the same set of people that will likely use this as well. It could be positive for O, meaning surface polysaccharide antigens, or H, that is flagellar antigens. Still on diagnosis, the recent rapid antibody-based diagnostic test. For example, in carriers of typhoid, the enzyme-linked immunosorbent assay for antibodies to the capsular polysaccharide V antigen could be helpful, but not for diagnostic purpose in the acute phase. Then, polymerase chain reaction has limited sensitivity anyways, and with that, because we'll be dealing with low concentration during bacteremia. Then antibody test to detect serum IgA against hemolysin E, or promising procedures. Other diagnostic parameters that we will go for will be complete blood count. We want to know if we are dealing with anemia here or not. Liver function test, renal function test, clotting profile, group and cross-match. Why that? There may be perforation with massive internal bleeding, and then you need to transfuse later on. Ultrasound to see what's happening with the biliary system. CT for the same purpose. We want to see what's happening to the pancreas, to the liver, to the kidney, to all organs right there in the abdomen, and even CT of the head, because we are talking about neuro complications, meningitis, encephalitis, and delirium, and so on. So we want to know what's happening there. X-ray of the chest and abdomen of the chest, because there is likelihood of pneumonia complicating typhoid fever, and you might even want to rule out community-acquired pneumonia using the chest X-ray right now. And of course, the X-ray of the abdomen will show us fluid or air level when there's intestinal perforation already. Now, the lab features will help us to know if we have anemia or we are dealing with leukopenia with left shift in adults, leukocytosis in children, and leukocytosis in third wave with intestinal perforation. Abnormal liver function test will all show up when the lab result is out. Salmonella hepatitis will give us abnormal liver function test. Raised C-reactive protein, lumbar puncture with mild pleocytosis. Pleocytosis simply means there is increased white blood cell in cerebrospinal fluid. Now the treatment. The treatment of typhoid will be mainly empirical in so many parts of the world where laboratory and detailed investigations could not be done. In endemic zones with poverty, remember, while going to the epidemiology, poverty will be the major factor that will lead to this problem in the initial stage. And now they don't have the gadgets to do all the big investigations, and you want to treat, you want to save their life. So, high index of suspicion, and then that will lead to the diagnosis, and at the same time, you commence treatment empirically. So you give empirical antibiotics in that case. So we have to take sample for microscopy, culture, and sensitivity first before we begin the empirical antibiotics. Here, we can choose fluoroquinolones, ciprofloxacin or floxacin, third generations of cephalosporins, ceftriaxone, ampicillin, azithromycin, cotrimoxazole, that is Bactrim or Cetra or Cetrin, chloramphenicol, chloramphenicol. As a matter of fact, I will talk more about this in a bit. Chloramphenicol. Chloramphenicol has limited usefulness. Why that? There is now increased rate of drug resistance to chloramphenicol. Now, I promise, and let me fulfill the promise right now. Chloramphenicol. Chloramphenicol is cheap, used in poor communities around the globe, but it has limited usefulness because of the increased rate of drug resistance. Besides that, you run the risk of aplastic anemia in patients taking chloramphenicol. There's low risk of fatality due to aplastic anemia. Let me explain. It means that there's likelihood of fatality due to aplastic anemia, but is low. So don't let us just paint it as if it's not happening. It is happening, but not so massive. So we can just summarize that chloramphenicol can lead to aplastic anemia that could be fatal. Its use is restricted in many countries. Why that? Increased drug resistance to chloramphenicol, aplastic anemia, and fatality that may follow. It's not even available in many countries because you don't want this trouble, right? In acute phase, we need to ask ourselves about certain things. Is this patient stable? If the answer is yes, okay, that's a way to go about it. Is this patient unstable? If the answer is yes, the patient is unstable, okay, then we know the direction to go. Do we need surgery right now? Am I going to write a consult to send to the surgeon? Do I need immediate resuscitation right now? Is this a mild or severe condition? So we need to make the determination very quickly, within 1 to 5 minutes. Then we should know where we are. Are we dealing with drug resistance in this locality, or where this patient has traveled or emigrated from? Now, Acute case scenario. Patient is unstable. Okay, airway. We check the nostrils, the mouth orifices, look for foreign bodies, secretion, suction as is appropriate. And is the airway patent? Make that determination. Breathing. What is the color? No. Any central or peripheral cyanosis? What's the respiratory rate? About air entry into the lungs? Is the chest moving with abdomen? No. Any deformity that is obvious, trachea deviation, and so on? We'll do that and ask the nurse, what's the O2 sat, please? Then we'll move to circulatory system. Any dehydration here? Capillary refill. Now, what is the blood pressure? What's the heart rate? We'll make that determination and check for edema peripherally. And of course, we'll set up our IV lines, 2 of them, quickly. Hook up the IV fluid that is appropriate for that particular patient and status. Folate catheter, because to catheterize the bladder, we want to know fluid in and out. Vital signs machine should be hooked up because we want to know what's happening to the temperature, the pulse, that is heart rate, the blood pressure, then the respiratory rate, and of course we cannot measure pain for now. Blood transfusion or not, we will have to make that determination whether we're going for that and then see whether the group and cross match is around, whether the blood is around. We pray that this is not going to be a woman that is O negative. Empirical antibiotics with or without dexamethasone. We will need dexamethasone if there is inflammation of the brain right now. So we'll need dexamethasone to help. And of course, empirical antibiotics can be administered. But we must have taken the sample for microscopic culture and sensitivity. But is the result here right now? If the answer is okay, we'll select the specific antibiotics at that time. So we will check our antibiotics box for what? For fluoroquinolones, for third generation cephalosporins, for azithromycin, chloramphenicol, if that is what the patient could afford, depending on the locality. But now that there's high level of drug resistance to chloramphenicol, we should be careful and also be mindful of their aplastic anemia. Carbapenems should be available. Why that? If we are dealing with multi-drug resistant strains, we should go for carbapenems. We should consider the geographical place we are and the degree of resistance and susceptibility. Like some regions, they've discovered now that there is resistance to chloramphenicol. So consider that. So giving chloramphenicol is not helping the patient. You are only adding to the possible side effects of aplastic anemia that may eventually kill the patient. Severe cases should warrant intravenous route medications like ciprofloxacin 400 mg intravenously twice daily for 7 to 10 days. The maximum we can give per day is 1 gram. In children, depending on the age of the child, but now, because I'm not too comfortable giving fluoroquinolones to children less than 8 years, and some textbooks will say 10 years, in that case, if we just have to save the life and it is only ciprofloxacin that is available for those few days, we might go ahead with that. But if other medications are available, I will skip ciprofloxacin for all children, all breastfeeding mothers, and or pregnant mothers. So in that case, you can go for this dose, and the maximum you can give will be 800 mg per day. So, chloramphenicol. If that is what is available, if you are not dealing with drug resistance to chloramphenicol in your region, then you can go for chloramphenicol 20 to 25 milligram per kilogram intravenously every 6 hours for 14 to 21 days. You can grab ceftriaxone 2 gram intravenously once daily, and some will go for twice daily for 10 to 14 days. Or if you are dealing with children and you want to use ceftriaxone, you grab your calculator, 15 to 25 milligram per kilogram intravenously every 24 hours for 10 to 14 days. Carbotazine 1 gram or 2 gram intravenously every 6 hours or every 8 hours for 10 to 14 days. In children, if you want to give carbotazine, then you grab your calculator and compute 30 to 50 milligram per kilogram intravenously every 6 hours for 10 to 14 days. Still on treatment, if the situation is not so severe, meaning the patient is stable, he or she is not vomiting, and you are sure this patient is going to comply with your prescription, then we can choose per agents. At this time, we can choose chloramphenicol. Again, why is this doctor picking chloramphenicol all the time? We need to face the fact the people that will be down with typhoid fever mostly are poor people, so chloramphenicol is cheap, and if there's no drug assistance in their region, and it's not what you use all the time every year in this patient, you still use it, but just watch over the aplastic anemia side effects. Okay, chloramphenicol 500 milligram or 750 milligram every 6 hours for 14 to 21 days. In children, chloramphenicol 15 to 25 milligram per kilogram every 6 hours for 14 to 21 days. You can go for azithromycin, 1 gram start. Then 500 milligram once daily, or you go for 1 gram once daily for 5 to 7 days. Children, azithromycin will be 10 to 20 milligram once daily for 5 to 7 days. You can also go for ciprofloxacin. I will not waste your time repeating everything about ciprofloxacin that I've said in the past. You can pause and rewind and get the facts about ciprofloxacin, okay? Amoxicillin, if not allergic to penicillin. Cotrimazole, that is either Bactrim or Septra or Septrin. Now, if there is multi-drug resistance or failure in your region, you may choose from other strong medications in the face of multi-drug resistance. That is meropenem, imipenem, ertapenem, or doripenem. So gabapenem could be chosen this time. In shock or coma with severe illness, you can add dexamethasone 3 mg per kilogram start, then 1 mg per kilogram every 8 hours for 8 doses. You can add the above to chloramphenicol as it may be necessary. Surgery. If peritonitis has occurred, and that is as a result of intestinal perforation, then consult to the surgeon. At this time, we must add broad spectrum antibacterial agents to cover both aerobic and anaerobic organisms. Follow up. Fever may persist till 1 week after the treatment. Fever can resolve and relapse after 3 weeks with chloramphenicol use. So if that is the case, you can change to ceftriaxone. Maybe at this juncture, our advice is just a piece of advice that keep chloramphenicol away if you can. Maybe you write letter to the government, of your state, province, or country, as the case might be, because this presentation could be listened to in any parts of the world. So, write that chloramphenicol is no longer ideal for the treatment of typhoid in my zone. It would be better that we go for stronger antibiotics like ceftriaxone, azithromycin, fluoroquinolones, and so on. Typhoid vaccines. Prevention, they say, is cheaper than cure. That is if the condition is curable at all. We've gone through what typhoid could do, right? Okay. What can we do not to have typhoid? First thing first, sanitation. We'll go to that in a bit. So sanitation, then vaccination. How about vaccination? Okay. The typhoid vaccines could come under different brand names. Typhoid V1, Vivotiv, Typheris, Typhora. There are different types like TY21A, that would be live attenuated. That was licensed in Europe in 1983. V1 polysaccharide, that is polysaccharide subunit, was licensed in United States in 1994. And TCV, that is typhoid conjugate vaccine, was licensed in India in 2013. The IM route, when you give typhoid vaccines per IM, that is the route for the non-live attenuated. Then ask me the question, what is the route for the live attenuated typhoid vaccine? I want somebody to answer that. Okay, let me supply is per oral. Okay. The typhoid vaccine belongs to the class of medications that inactivated and live attenuated vaccine. It depends. There is inactivated typhoid vaccine, then there is a live attenuated typhoid vaccine. Dosage forms. The live attenuated will come in form of capsule for per oral use and is enteric coated. The non-live attenuated example would be typhoid V1, that is purified V1 capsular polysaccharide at 25 microgram per 0.5 ml from Salmonella typhi T1 strain. Typheris is V1 capsular polysaccharide and Vivotiv is viable S typhi TY21A 2 to 10 times 10 raised to power 9 units as a form of injection, and it is inactivated. Typhoid vaccines administration. I've written here that you should ask me about how to give the IM or per oral. Okay, let's go through that. If you want to give the IM to an adult, you give it at the deltoid, okay? Let the patient be seated, or patient can lie supine, okay? Why that? We want to prevent syncope, okay? You can use 23 gauge or smaller needle, and you apply pressure at the site, and then warn about possible hematoma. I mean, you warn the patient that it's likely that there may be hematoma afterwards. But the per oral use, you can give the capsule, and the capsule should be swallowed whole. The patient should not open the capsule, and it should not be chewed. Okay, it can be taken with cold or lukewarm beverage, and to be taken 1 hour before meal. And the individual must avoid alcohol. Avoid alcohol 1 hour before and 2 hours after. Okay. In pediatric age group, the IM could be given at anterolateral thigh or deltoid as well, but no subcute and no intravenous administration. Uses. Typhoid vaccines is used as immunization against Salmonella typhi for travelers to the endemic zones. Those with the history of contact with carriers or active infection with Salmonella can take typhoid vaccines. Lab technicians exposed to Salmonella typhi should take typhoid vaccine. Individuals with decreased immunity and traveling to endemic zones should take it. But it is not one of the routine vaccines. No. The typhoid vaccine is ineffective against most Salmonella paratyphi. When vaccinated travelers are infected, it is most likely going to be paratyphoid. Okay? So V1 polysaccharide typhoid vaccine, but Salmonella paratyphi lacks the V1 polysaccharide antigen. Now, the typhoid vaccines, and let's look at them individually. V1 polysaccharide vaccine is a single IM dose or subcutaneous dose every 2 to 3 years if you're traveling so frequently to the endemic zones. The TY21A vaccine is live attenuated, and since it is live attenuated, will be taken per oral. So you take it per oral start, that is right now, then alternate days to a maximum of 3 to 4 doses. For example, you can have the first dose on a Sunday, the second dose on Tuesday, the third dose on Thursday, and the fourth dose on Saturday. You revaccinate every 3 to 5 years with the live attenuated, that is the TY21A. The TCV or typhoid conjugated vaccine is also known as V1-TT. Here, the V1 antigen is linked to tetanus toxoid. It's given as IM single dose. It is not available in Europe and North America. Then ask me why it is available. It's available in India, some other parts of the world. Vivotif per oral will have 4 doses, 1 capsule on days 1, 3, 5, and 7, given a week before traveling into the endemic zone. Repeat the full 4 doses every 5 to 7 years. Typhoid V1 or Typhoid is given intramuscularly at 0.5 ml, given at 2 weeks before traveling to the endemic zone, and you repeat that every 2 years or every 3 years. Dosing in pediatric age group. It's the same as in adults, and at the same time intervals, but you give per oral only if the child is greater than 6 years, and you give the IM only if the child is greater than 2 years. Typhoid vaccines adverse reactions. Induration and pain are the site of the injection. The individual may feel malaise, can have headache, can have fever. There may be muscle tenderness, there might be joint pains, and itching. Other adverse reactions might be anaphylaxis, nausea and vomiting, Guillain-Barré syndrome, dizziness, hypotension, angioedema, and abdominal pain. Remember, I have a full presentation on angioedema, both hereditary and acquired angioedema. You can check my channel for that. Contraindications to typhoid vaccines. Hypersensitivity to the components of its formulation. Now, once that is the case, no typhoid vaccine. If there's that history of hypersensitivity to typhoid vaccine in the past or to any of its components, no, we're not giving it today. Pregnant? Yes, doctor. No. Pregnancy, typhoid vaccine is contraindicated in pregnancy. Immunocompromised will not take the live attenuated vaccines. Inflammatory bowel disease? No. Acute febrile illness, acute gastroenteritis are contraindications to typhoid vaccines. Drug-drug interactions. Well, no one can know it all. Contact a pharmacist or clinical pharmacologist to guide, because I may not be able to say precisely which medications you are taking or you are about to take, and therefore let your physician guide with the help of the pharmacist or clinical pharmacologist as per drug-drug interactions when it comes to typhoid vaccines. Monitoring of typhoid vaccines. Wait 15 minutes and check for anaphylaxis or syncope. For that is the norm. While administering many of the vaccines that may eventually lead to anaphylaxis, particularly in people taking such vaccines for the first time. So don't be upset when you are told to wait for 15 minutes. And if that is the case, if anaphylaxis is present, we have to jab the patient with EpiPen. EpiPen in North America, adrenaline in Europe. And we have ready Benadryl, corticosteroids, with or without salbutamol, all to reverse anaphylactic reactions. We'll place the patient's supine with an elbow position to enhance cerebral perfusion in anaphylaxis and syncope. 1. There may be syncope, there may be shoulder pain and bursitis from deltoid injection site. Hypersensitivity could not be completely ruled out. That is why when there's history of hypersensitivity to typhoid vaccine, then that will make it to be contraindicated in such an individual. Be careful in bleeding discouragements. Never for the treatment of typhoid fever. Let me explain. Oh, okay, this patient had already visited endemic zone or lived in endemic zone and already ingested or acquired the causative agent salmonella, and now down with the infection, and then the next thing you look for is the typhoid vaccine. No. It's not for that. It's for prevention, not for the treatment. Defer. If there's persistent vomiting and diarrhea, and you want to give it per oral, no, not right now. Still on warnings, don't use anticoagulants while using the IM route. You know the reason? Very obvious, right? If immunocompromised, no live attenuated, may not give an effective immunity in some recipients. So let's tell the truth. The fact that the vaccines are available and we are administering them right now is not guarantee that immunity will be there. So let us face the fact. May not give an effective immunity in some recipients. Okay. If you have to travel to the endemic zone, the IM formulations, the ones you can give by injection intramuscularly, should be given 2 weeks before you land in the endemic zone. If you are going for the per oral agent that is live attenuated, the capsules should be given 1 week before you land in the endemic zone. Prevention of typhoid. Yeah, I'm pretty interested here. My entire channel is built because we want to reduce suffering and death worldwide. No, so that people will become aware of what they can and cannot do to live longer. So when it comes to typhoid, and you don't want to be down with typhoid, start with hygiene, food hygiene, water hygiene. Anything that goes into your mouth, anything you are going to swallow, be careful. Let it be hygienic. Public health screening or food handlers will help. You can enact some bylaws in your locality, in your jurisdiction, to help. I know people that are handling food should be tested, should be screened. Get their urine, get their stool. You may even collect blood for culture. Just be sure they are not disseminating salmonella. Okay? Traveler's guide on what to eat, what not to eat, where to eat, where not to eat. And some, it's there that don't eat fruits that are not properly washed. Don't drink water just anyhow, or water, packaged in nylons, in some dirty bottles. Go for, particular sort of water. All this will be there. What to drink, what to eat must be properly cooked. Roadside fruits, roadside water, roadside drinks are not okay. No. Vaccinations to travelers going to endemic zones and the dwellers in endemic zones will help. But I've said, truth be told, it's not a guarantee that you will actually be protected. And most of these vaccines will cover Salmonella typhi, not Paratyphoid. Prognosis. Mortality used to be very high. I said used to, as in the past. As high as about 15 to 20% would die in those days due to typhoid. But as of today, that has changed. It's changed for better. It has dropped now to 1% or less in recent years. Some will have a prolonged illness after treatment, and some will have debilitations after perforated surgery. Remember, when surgery is the case in perforated intestine, complications of the surgery, the anesthesia, the transfusion, the wound, the dehiscency breaking down, and later on, having intestinal obstruction from adhesion, and so on. All these are there, okay? Relapse is pretty common if not properly treated. That's why we've gone through all the agents we can choose from: cephalosporins, fluoroquinolones, macrolide like azithromycin. You can use amoxicillin sometimes, and you combine amoxicillin with clavulanic, giving you clavulin, and so many good medications that we choose from. Some are still using chloramphenicol right now. I've gone through what you're likely going to be faced with if you are using chloramphenicol. And when you are dealing with multi-drug resistance, you go for carbapenems. Oh, we've reached the last bus stop. Conclusion. Typhoid, or otherwise known as enteric fever, can kill, but should not be killing us because it is treatable. Yes. And it is also preventable. So, let's go over this entire presentation again and see how we can prevent this. And if you are a healthcare provider, how can you treat this? Because If prevention fails, treatment must not fail. That man or woman should not be killed by typhoid or enteric fever anymore. With that, I've come to the end of this long presentation on typhoid fever. Thanks for listening. Thanks for remembering to share this with all your friends on your platform. Remember to subscribe if you haven't. Remember to leave your comments. I will gladly appreciate that. Thank you.